In this video, we're going to talk about the basics of peripheral arterial disease. Surgeons love their definitions, so the definition of PAD is narrowing or occlusion of the arteries in the legs, the extracranial arteries to the brain, the abdominal viscera, and the arms. And the most common cause is atherosclerosis. It's a common condition. It affects about 10 to 20% of men over 50. It's more common in men. It increases with age, and there's geographical variations in the prevalence and incidence. By far the biggest risk factor for the development of peripheral arterial disease is cigarette smoking. Other conditions which may increase the risk are diabetes and long-term hemodialysis. And then there are a number of associations. So patients with peripheral arterial disease are also more likely to have occlusive arterial disease in other beds like their heart or their brain. They may have high cholesterol, they may have high blood pressure, and there may be a family history. The term peripheral arterial disease is an umbrella term which simply refers to underlying occlusive disease of an artery. It doesn't refer to any particular clinical syndrome from it. But this causes a lot of confusion, as people tend to use the term peripheral arterial disease and take it as being synonymous with claudication or chronic limb-threatening ischemia. And it's important to realize that it is not. So peripheral arterial disease can present in three ways. The vast majority of patients are completely asymptomatic. This is 9 out of every 10. 8% of patients, or 8 per 100, will develop intermittent claudication at some point, and 1 in 50, or 2%, will go on to develop chronic limb-threatening ischemia. All three of these presentations, asymptomatic, claudication, and chronic limb-threatening ischemia, come under the heading of peripheral arterial disease. But as we'll see later on in other videos, they need to be dealt with in different ways. Peripheral arterial disease is diagnosed on the basis of an ankle brachial pressure index. And we've discussed this in another video, but just to remember, an ABI of less than 0.9 means PAD, 0.9 to 1.4 is normal, and an ABI over 1.4 means the vessels are stiff and incompressible, and you cannot be sure whether they do not have PAD. And in all of this, you will see no mention of whether or not they have claudication or chronic limb-threatening ischemia. That's because all the ABI tells you is that they fall under the umbrella category of having peripheral arterial disease or not. We said the majority of PAD patients are asymptomatic, so they look very well. It is important to remember, though, that the risk of cardiovascular death for patients with peripheral arterial disease is equivalent to that in patients with coronary or cerebrovascular disease. So how should you detect patients with asymptomatic peripheral arterial disease? Because obviously, by definition, they have no symptoms, so they're not going to complain about anything. There are some things in their past history which should alert you to the possibility and make you check. So, in particular, are they a current or an ex-smoker? Are they diabetic? Have they a previous history of ischemic heart disease, valvular heart disease, or cerebrovascular disease? Have they previously had lower limb revascularization procedures? Do they have high blood pressure? And do they have high cholesterol? The presence of any of these in their past history should alert you to the possibility that they may have asymptomatic peripheral arterial disease. If features in the history alert you to the possibility of asymptomatic peripheral arterial disease, you might be able to find some supporting evidence on examination. But the examination findings in asymptomatic PAD tend to be a lot more subtle than those found in patients with claudication or patients with chronic limb-threatening ischemia. So you want to look for hair loss distally. There may be a temperature gradient with the leg being warmer more proximally than it is distally around the foot and toes. They may have thin, shiny skin and hypertrophic nails, and they will have diminished or absent pulses. So your history has alerted you to the possibility of asymptomatic PAD. On examination, you found that they have diminished or absent pulses together with some other supporting evidence of asymptomatic PAD. How are you going to make the diagnosis? As we said before, it's diagnosed on the basis of the ankle brachial pressure index. So a range in ABI, if it's less than 0.9, they have peripheral arterial disease. Once you've established that your patient has asymptomatic peripheral arterial disease, what are you going to do with them? Well, there's two elements to management. One is risk factor modification, and the other is checking for related pathology. The aim of the risk factor modification is to try and reduce the risk of an acute cardiovascular event or cardiovascular death. So they should all be prescribed an antiplatelet and a statin. If they have high blood pressure, it needs to be controlled. If they're diabetic, they need good glycemic control. The second element is checking for related pathology. Obviously, smokers are at increased risk of PAD. Smokers are also at increased risk for abdominal aortic aneurysms, so it's unsurprising that there is a relationship between the presence of PAD and the presence of AAAs. So I send all of my PAD patients off for an ultrasound of their abdominal aorta to rule out an aneurysm. Carotid screening in this particular situation, however, is very controversial. The US Preventive Services Task Force looks at this every couple of years and have just issued updated guidance in 2021, which again recommends against screening for asymptomatic carotid artery disease in patients who do not have a history of stroke and who do not have neurological symptoms. So I do not send my PAD patients for carotid screening. You might have noticed that at no point in the management suggestions did I mention either imaging of the lower limb arteries or any suggestion about revascularization procedures. The reason for that is that there is no indication for revascularization procedures in patients who have asymptomatic peripheral arterial disease. The only reason for arterial interventions in the leg is to treat debilitating symptoms or tissue loss in chronic limb-threatening ischemia. If you are not going to intervene on the patients with a procedure, there is no need to waste time and money sending them for imaging. The purpose of imaging is not to decide whether or not a patient has a procedure, it is to decide what type of procedure is technically possible in a patient for whom the decision to operate has already been made. So there is no role for imaging in asymptomatic peripheral arterial disease other than an aortic ultrasound. And there is no role whatsoever for arterial intervention in the management of these patients. Other than medical therapy, they should be left alone. Thanks for watching. Remember to give the video a like, to think about subscribing to the channel, and for those of you who want the written revision notes, they're available as always at vasculartutor.com.